to send those slides, basically for the general introduction of BPDCN. But thank you very much, Dalton, for the program, for your kind introduction, and for everyone who could join us. And of course, it will be recorded and will be available. And of course, I have a long association with HealthTree Foundation and HealthTree University, and they have been doing a phenomenal work in so many different diseases, and especially with multiple myeloma, which was the start of my association with HealthTree. So as almost all of you or most of you know, BPDCN, or Blastic Plasmacytoid Dendretic Cell Neoplasm, is a relatively new diagnosis. The disease existed, but of course, either we didn't know about it or didn't know it with this name. But now it is much better characterized, and according to the most recent classification, this is the official name of the disease, and it is a type of acute leukemia, an aggressive hematologic malignancies. So this is what I'll be focusing on. So BPDCN is different for other types of blood cancers or hematologic malignancies, in the sense that it has this predilection for involving skin. So overwhelming majority of patients, and depending on what study one looks at, 75% or more patients may just present with changes in the skin. It could be either one area or more than one areas, and there could be just a small flat purplish or reddish area, which can grow into a plaque and then sometimes into a tumor or a nodule. So this is how most patients who have any knowledge or who are diagnosed with BPDCN know about it, that it's a type of blood disease, type of acute leukemia that can present as a skin lesion. But if you look deeper, it can also involve blood and bone marrow system, because after all, it is a type of blood cancer which originates in the bone marrow. And then it can also involve other parts or other organs as well, like lymph nodes, liver, or spleen. And one critical thing that we look for in every BPDCN patient at the time of diagnosis is the spinal fluid or brain, because even if there are no symptoms, according to various series and reports, up to a third of patients may have involvement of cerebrospinal fluid. So we always, in a newly diagnosed patients, do a lumbar puncture to look for any spinal fluid or central nervous system involvement. And of course, the management depends on whether the disease is there or not. And I will come to that. So like in any disease or in any cancer, we first want to know that how common is it? So of course, it is an extremely rare. So first of all, just to give you a perspective, blood cancers are a small part of overall cancers. Only about 15 to 20% of cancers that are diagnosed are blood cancers. And acute leukemia is a small part of those 15 to 20% blood cancer. And BPDCN is less than 1% of that acute leukemia population. So it is extremely rare. And part of that, I think the incidence may go up. It's because many people didn't even know what BPDCN was, or if this was a unique diagnosis and is it different from other type of blood cancer. So, but bottom line, that it is an extremely rare form of acute leukemia. The average age at diagnosis for BPDCN, just like most blood cancers, whether it is acute leukemia or chronic leukemia, is patients in their 60s. But that doesn't mean it does not affect younger patients. Of course, as we understand more about the disease, we're seeing younger patients who are diagnosed with BPDCN, including some pediatric population or children. So, and again, so far, based on those reports, and most of those are from either single center or retrospective reviews from multiple centers. More males are affected than females, but that number may change as we have bigger data of diagnosis and patient characteristics. So these are some of the statistics. Another important thing to know, and that is because of the age at diagnosis, that about 10 to 20% of patients with BPDCN may have a second or a different type of blood cancer at diagnosis. And I've seen that in my practice also. That same patient may also have a myelodysplastic syndrome or a chronic myeloid leukemia, or I have had a patient with ALL at the same time as they were diagnosed with BPDCN. So when we look at the bone marrow biopsy, we look carefully with our hematopathologist that there is no other type of blood cancer present. Then, of course, the question that we get asked by our patients, well, where did it start? How did it start? Are there any risk factors? And like most patients, we're not aware of any classical risk factors, like it is not, at least so far, we don't know that it is what kind of environmental exposure or what kind of genetic predisposition there is. So that we do not know, but what we do know is that it is a type of blood cancer, and it basically starts from these cells called plasmacytoid dendritic cells, which are part of our immune system. And these cells acquire these mutations, they migrate to the skin, and that's where they basically start to form these tumors, which can manifest initially as like a purplish lump on the face. And then when you look deeper, you may find that it's also in the bloodstream or bone marrow. So this is what we know on how this disease originates. And then, of course, most important part, how do patients present? And that's where I started by saying that one unique feature that the majority of patients have something on the skin. Now, again, changes in the skin are so common. We all have some little bump or a little discoloration of the skin. But of course, the important thing is if there is something that continues to change color, started out as something red and flat, and now it is becoming purplish, it is growing, it is getting thicker, it's turning into a tumor, multiple nodules. So those are the type of presentations that I've seen that patients have come to attention, and they would see a dermatologist, and then eventually when they get the skin biopsy, they would get the diagnosis of BPDCN. So that is one common presentation. But then patients can also present like other blood cancer patients, that they're feeling tired and weak, or ended up with an infection and then went to the emergency room or hospital and found out that their white blood cell count is very low, or their platelets are low, and that's why they were having these small pinpoint hemorrhages or easy bruising, or they were really weak and tired, getting exhausted with activities that they were able to carry out all their life, and found out that they were severely anemic. So that is another way of disease presenting. In a small proportion, I've seen patients presenting with big lymph nodes. Uncommon, but it can also be seen. And then, like I mentioned, that neurologic or CSF involvement. So occasionally someone may just show up with severe headaches or involuntary movement. But luckily, those presentations are extremely rare. Mostly, it is the skin and the blood and bone marrow involvement that are common. So how do we basically, what are the things that we do if a patient like this shows up at a doctor's office who's not, of course, a BPDCN specialist because it is such a rare disease? So, of course, people start out by doing simple blood tests, looking for blood counts and all. They would, again, look at chemistries, rule out infections. And then, of course, dermatologists are also an important part of that team that helps manage BPDCN. They look at the lesions. They could differentiate it from other common problems. They would tell us that, yes, a biopsy is very much warranted or needed, and then that biopsy can then confirm the diagnosis. Another thing, of course, if the blood tests are abnormal, or even if the skin biopsy shows BPDCN, a bone marrow biopsy is absolutely essential because it is a blood cancer. So we have to know more about it by doing a bone marrow biopsy. And then because this disease can also present with lymph node or liver involvement, most patients or almost all patients also need at least some kind of imaging or scanning, like a PET scan at the time of diagnosis. So these are some critical tests that we perform. I mean, we'll have a dermatologist see our patients. We would do skin biopsy and then definitely a bone marrow biopsy and some kind of imaging. And then, of course, like I mentioned, that anywhere between 10% to 30 to 33% patients can also have spinal fluid involvement. So once we establish the diagnosis, we definitely do a lumbar puncture to look for any spinal fluid involvement. So these are some of the things that are critical to establish the diagnosis. So how do we make the diagnosis? How do we confirm that someone has BPDCN? So like any cancer, the real evidence is in the morphology, the histology. You look at it under the microscope. And when you look at it under the microscope, whether it's the skin biopsy or the bone marrow biopsy, you see those typical cells, which look like malignant cells, malignant blood cells, the so-called blasts. And then we can further identify their characteristics by something called flow cytometry or immunophenotyping, where not only how these cells look under the microscope, but what kind of special features do they have? They have certain molecules or antigens that are present on their surface, and that's what we can pick up. So some important things that under the microscope, you would see these blasts, which are Blastic, Plasmacytoid, Dendretic cells, and they have some very unique features. So one thing that one of my good friend and colleague, Dr. Naveen Pemaraju, who is one of the foremost specialists, one of the top specialists of BPDCN, he says 1, 2, 3, 4, 5, 6. Always remember. So CD123 is one of the markers. And then you have two other features. These cells are also CD4 positive and CD56 positive. So CD123, CD4, CD56. These are different antigens that are present on the surface of these cells. So this 1, 2, 3, 4, 5, 6 is a very easy way of remembering these characteristics. And then there are some other features of these cells that the hematopathologist through flow cytometry can identify. There are, of course, some genetic features based on cytogenetics, based on molecular studies, but there is no unique abnormality. Like if you've heard of the disease called CML, it has a very unique chromosomal abnormality, something called Philadelphia chromosome. Unfortunately, we do not have a very characteristic abnormality that is seen in BPDCN yet. But you can identify some chromosomal abnormalities, some molecular abnormalities, some gene mutations. And one of them that we see with a great frequency is called TET2 or TET2 mutation. And that is a tumor suppressor gene. Normally, we have these oncogenes which can promote tumors, and then we have these genes that protect cancers from being formed in our body. And there is a very, very good balance between the two. But if we lose some tumor suppressor gene like TET2 or P53, or they get mutated, then their function is impaired, and that can help in cancer formation. So this is one of the things that you may hear about if you or a friend or a family is dealing with BPDCN. So these are some of the characteristic features of diagnosis. And then, of course, once we have established the diagnosis, then it's all about treatment. How do we treat these patients? So I am an adult hematologist, oncologist. So of course, most of my patients are adult patients, but it can also be seen in pediatric population. And those patients more or less are treated the same way as adult patients. So I divide the treatment of BPDCN. First, I want to see if my patient is medically fit or medically unfit. I think most patients fall, and maybe partly because of my practice, most of the patients that we have seen are in that medically fit category. And even if they are not fit, it is probably because of the disease. And when you treat them, their overall health improves and they can tolerate aggressive treatment. But that's a very critical point, that is someone medically fit or unfit. Medically unfit, an older patient with a lot of medical problems that preceded the diagnosis of BPDCN, where aggressive treatment may not be an option. So we'll discuss that later. Most patients are medically fit, and how do I treat them? Well, so I divide that into like three important components. First is I look at their CNS or neurologic or brain or spinal fluid involvement. Do they have any involvement of that or not? Second, what we call induction treatment. That's the first treatment. What chemotherapy, what targeted therapy do we use? Third thing, what we call consolidation or post-remission. After they have completed their induction treatment, their first treatment, what else do we need to do to cure this patient? And then, of course, once the treatment is completed, then it's the surveillance. We, of course, after completion of treatment, don't forget, we have to then continue with a follow-up plan. So we make sure that patients are doing well, they are in remission. And if there is any risk, any chance of recurrence, we pick it up early. So these are the most important components. So first, let's come to the spinal fluid test, or looking for CNS involvement. So we do lumbar puncture, and about a quarter of the patients to a third of patients may have spinal fluid involvement, even if they don't have any symptoms. So that's why it's important to do that. If patients do not have any spinal fluid involvement, we use what's called the preventive or prophylactic approach, where we give chemotherapy in the spinal fluid, but less frequently, like every 2 weeks, and give up to a total of 8 doses. So this is the preventive approach. So this prevents, even in those patients who do not have any spinal fluid involvement, we give this intrathecal therapy to prevent spinal fluid from getting the disease in the future, because it's hard for drugs to penetrate that area. And in those who do have disease in the spinal fluid, we use the treatment approach rather than the preventive or prophylactic approach, where we use the same treatment, the intrathecal chemotherapy given in the spinal fluid, well, but we do it more frequently, like twice a week until spinal fluid is cleared. Generally, it takes 2 to 3 doses in most patients to clear the spinal fluid. And then we give it less frequently, again, for up to 8 or more doses. So this is the approach for the spinal fluid. The second part is induction treatment. Now that you have the diagnosis, you've taken care of the spinal fluid, how do we treat these patients? At this point, I think there are two main approaches. One is conventional chemotherapy, and the second approach is targeted therapy. So the conventional chemotherapy, until we got the targeted therapy, was that people used the regimens that were used to treat acute leukemia, whether ALL or AML or lymphoma. So you may have heard of, and I'll send some slides which will be available in the video presentation and the video recording later, that there are these regimens called CHOP or 7+3 or hyper-CVAD. These were the combination of chemotherapy drugs that we had used to treat different types of leukemia and lymphoma. So this is one approach of treating or doing the induction treatment. And the goal is to rapidly eradicate the disease from everywhere. Skin, bone marrow, lymph node, liver. So that's one approach of treating. Second approach, which of course, as we learned more about it and with advancements in technology and molecular biology, we have an FDA-approved targeted drug called tagraxofusp, Elzonris. So I mentioned 1, 2, 3, 4, 5, 6. So this one is targeting CD123. So this drug, which is approved by the FDA after a pivotal trial that was published about 6 years ago, can directly target the molecule on the surface of BPDCN. So tagraxofusp is the targeted treatment for BPDCN. Now, one may ask that, is it better than conventional chemotherapy or worse? Well, we have not done, or because it's such a rare disease, we cannot do head-to-head comparison. But my center and others have looked at the outcome of patients who have received both chemotherapy as well as tagraxofusp. And overall, one can safely say that they are both effective approaches. And there was no real difference in the overall outcomes of survival of patients, whether they receive targeted therapy or aggressive chemotherapy. And the proportion of patients that go on to get bone marrow transplant or stem cell transplant is also about the same, meaning that these approaches can rapidly control the disease and allow the patient to seek their curative treatment, which is the transplant. So this is tagraxofusp. It has some unique side effects. One that you may want to remember is something called capillary leak syndrome. It can cause, it's an intravenous drug. It's given for about 5 days consecutively. First cycle is generally given in the hospital because of this side effect of capillary leak syndrome, which from the patient standpoint is something that can cause drop in blood pressure, that can cause shortness of breath, that can cause swelling in the body, that can cause total albumin, which is part of our protein, to drop. So there is the whole approach on how to manage that. So this is the targeted therapy, but they both produce very good responses and very rapid responses. So that is about the induction treatment. But if we stop treatment at this point, unfortunately, most patients, even if they achieve a complete remission, relapse. So that's why after that, patients continue with some additional treatment, which is what we call consolidation. And in most patients, if they are eligible and if they have a donor, so far the data support the role of allogenic stem cell transplantation. In other words, bone marrow transplant from a donor. Not everyone is eligible because it's a pretty intense treatment. Not everyone has a donor, although that has also improved because we cannot, if someone doesn't have a matched sibling, we can get an unrelated donor from the registry. And if they don't have an unrelated donor in the registry who's a full match, we can use a mismatch related donor. And in some patients, we can even use umbilical cord blood from newborn from the registries. So these are the allogenic transplant, but that generally comes after induction treatment. In those patients where an allogenic transplant is not an option, we, in some patients, select patients, have also been able to do autologous transplant using their own stem cells to achieve. But that is generally given to patients who have very limited disease and a very deep response. A donor transplant, because it also is a form of immunotherapy, is considered superior. And in those patients where none of those things are available, there are approaches where tagraxofas for Alzheimer's that I mentioned can be given for extended period as maintenance, although it is not an easy treatment in the sense that it is given intravenously and it has side effects, but it can be given for extended period. So this is generally the approach in the patients who are newly diagnosed and medically fit. In those patients who are medically unfit, meaning that they cannot tolerate very aggressive treatment, fortunately, we have learned that some of the other leukemia treatment that are less intense have activity against BPDCN. Venetoclax, a drug which is used in chronic lymphocytic leukemia or myelodysplastic syndrome. It's a pill, but it has activity against BPDCN. Similarly, what we call hypomethylating agents, other leukemia drugs that can be given intravenously and they are less intense treatment, and they can be combined with venetoclax. And data are emerging that in patients who are not medically fit to undergo intense treatment, these treatments can achieve responses. So that is another thing. And then on the horizon, there are a number of approaches, newer drugs that people are seeing, and one of them is an antibody drug conjugate. It's not FDA approved, but it is in clinical trial with some very good data, which is being tested, and that is also targeting CD123, and it has shown some very encouraging results in clinical trial called pivekimab. So you would see those data being presented at various conferences. So we will be hearing more about that drug if that moves forward in the treatment. And of course, when you reach out to experts, you'll hear about other clinical trials targeting other molecules at different centers. So now that we have learned so much about the disease, once we better understand the biology, that helps us in basically discovering or testing newer treatments. So I think I will stop here for a minute. I'll be happy to answer questions and elaborate on anything that you think I missed during my presentation.
That was wonderful, incredibly informative, and you were very, very clear on so many things. So really, I appreciate that. Now is the time for Q&A. So if you have any questions, please feel free to drop them in the chat. This time is meant to answer as many questions as we can. So don't hold on to them if you've got them. I did want to start off by asking, I've got a list here, but so you mentioned the skin involvement.
Sure.
Is it important for BPDCN patients to regularly see a dermatologist after they've already been diagnosed, or is it more of a, you get that diagnosis and then you're just more on the heme onc side of things?
Yeah, no, so we work very closely. Anyone with skin involvement, basically, so dermatologists are part of our team, and our patients who see us continue to follow up with their dermatologists who do a detailed exam because, of course, we are physicians, but we are not as well trained in looking at the variation in skin lesions. Of course, the longer out you are from your treatment with no recurrence of disease, those exams become less and less frequent. But early on, yes, you have to have regular follow-up with dermatologists, and luckily, they work very closely with hematologists, oncologists.
Okay. And then the next question that I had written down. Um, so is there any sort of familial component for BPDCN? Any sort of like genetic predisposition? I think is the same question we just got.
Uh, yes, so there is, once we know more about the disease, once more data emerge, you see that there is some familial association that someone's parent or sibling also had the disease. And you start seeing those clusters, and then you may see some common abnormality. It's not known at this point, but that doesn't mean that there is no association, because as we see more patients, some of those things will emerge because we do see chromosomal abnormalities. And once we start to see that some of them are more predominant in certain populations or families, we'll learn more about that.
So that one is we don't know the answer quite yet, partially just because it's such a rare disease that it's hard to really do these large scale genetic studies, correct?
Absolutely. And the second thing is that if you look at even the well-known diseases, it's of course there are families where a certain disease is more common, but there's still a small minority. Whether it is acute myeloid leukemia or multiple myeloma or non-Hodgkin's lymphoma, there are familial association, but they would be, I would say, less than 5% of the overall population. In more than 95%, those things are sporadic. They are just seen in one member of the family. So again, there's always could be a small component of genetic, some kind of genetic predisposition, but it mixes with some kind of environmental component. Again, in most situations, we do not know, but it's the interaction, that complex interaction, that leads to this malignant transformation.
And then next up, I wanted to ask, I think you touched on this one, but I just want to make sure that I'm clear on it. But is management of BPDCN different based on the different ages? So obviously, typically it's presented in older individuals, but pediatric versus adult versus kind of an AYA, are they all going to see pretty similar treatment regimen, or is it going to be pretty different?
So generally, and more of the oncology community, that age by itself is not the determining factor. So we do have patients who are 75-year-old and who have done allogeneic transplant and have done well. And then there are always exceptions where someone is younger, but because of all the other medical issues that they've had. So, but in general, yes, if you have a frail older patient, you would use what I mentioned, less intense treatment like venetoclax with a hypomethylating agent. But in most other patients who we consider medically fit, our goal is to go for the most aggressive treatment, which gives us the best chance of cure.
Okay.
So there is one question, yeah, is it also hereditary? I ask because my father had BPDCN as well as congenital thrombocytopenia, and both my sons have. So, that's a very good question. Simple answer is we do not know if the congenital or hereditary thrombocytopenia was in any way predisposing to BPDCN, because as I mentioned, there are a lot of BPDCN patients have a different blood disease, which may not have anything to do with that. So we do not know enough about this. Hopefully, congenital thrombocytopenia, which is not that uncommon a problem, and BPDCN is so rare. So most
Mhm.
people who have congenital thrombocytopenia are probably never going to get BPDCN. But it's a good question. And of course, if someone has this in the family, you're always concerned, and it may not be a bad idea. And I'm sure that since you know thrombocytopenia, so this is being followed by a hematologist, and when they will be looking at the blood counts and labs, and if it is still just thrombocytopenia and nothing else, I don't think it would warrant bone marrow biopsy or extensive workup for BPDCN. But I would, of course, leave that to the treating physician who knows more about the specifics.
Okay. And then I got another message. And this one is asking, what are the chances that BPDCN comes back after a bone marrow transplant? What is considered a quote unquote transplant fail?
Sure. So yes, and we and others have looked at that. So and these are data from my center at MD Anderson. We have now done allogeneic transplant in close to 50 BPDCN patients. Earlier on, we reported our results on 17 patients. So patients who did an allogeneic transplant in first remission, they were diagnosed, they received their induction treatment, and then came for transplant. 70 to 80%, as long as they did not have any life-threatening complications from transplant and survived those, 70 to 80% of those patients remain in remission and can be cured. But there is a small proportion which can still relapse. And after relapse, it's a very, very difficult to disease, very difficult disease to treat because of limited options. But that is getting better with the availability of newer and more targeted treatments. So yes, patients can relapse, but after relapse, like in any cancer, it becomes more challenging to achieve another remission, which is durable.
And then one that I was thinking about as you were speaking, with this disease being very rare, and you touched a bit on it a little bit, but finding a specialist for BPDCN is challenging. Where should most people be seen if they are diagnosed with BPDCN? Not everyone is able to make it down to MD Anderson.
Oh.
Um, who should be treating BPDCN patients?
Yeah. So I would, so of course, not, as you very rightly said, that not everyone has the resources or not everyone has the capability of flying to Boston or Houston to go to Dana-Farber or MD Anderson. But as long as, since it's an aggressive type of blood cancer, so at least see a specialist who treats leukemia or blood cancers. And pretty much wherever you are, within reasonable distance, there would be a cancer center where there are people who specialize in treating leukemia and lymphoma and blood cancer. So that would be my approach for those patients, because it is such a rare disease that you at least want to see a specialist once, and then they can work with your local oncologists, because of course those are extremely capable, very well-trained people. But of course, they see everything from breast cancer to prostate cancer to colon cancer. So they're not focusing on, but what we do, and we have these great partnerships, then patient comes and sees us, and then they go back and they get treatment locally, as long as patient and their local oncologists are comfortable and they feel that they have the resources to treat the patient, but basically stay in touch with that expert, whether it is say, Johns Hopkins or at Vanderbilt or UCLA, but stay in touch with a specialist who at least takes care of blood cancer patients.
Okay. That is good to know, because I know that that is a question that we get frequently of, and we always love to recommend people go and see these really hyper focused specialists, but with BPDCN being so rare, it can make it really challenging when there are just a handful of truly like full-time dedicated specialists for BPDCN. So just wanted to provide an option for people.
Absolutely. And of course, like my colleagues and I, we work with colleagues from all over. We get emails, we get calls from our colleagues who are treating that, I've got this patient and I know you guys have treated that. What would you do? What should I do next? So it's a very collegial thing, and this is the right thing because if I have a patient and I need to reach out to a colleague at another center, I do that. And everyone is gracious enough and helpful enough to get back with helpful suggestions.
Everyone wants to be as helpful as they can in this disease space. That is for sure.
Absolutely.
I'm trying to think if there's any other questions that I had, or if there's anything else that I wanted us to cover. Um, and let's see here. I guess, how do you think that the prognosis of BPDCN is going to change going forward? I know people may look around right now on the internet and find some disheartening things. Um, do you think that in the coming years we're going to see some major shifts here?
Absolutely. So first of all, what I would say is just like any other acute leukemia, if you reach the right physician, it's a potentially curative disease. Of course, it's a challenging path. Patients get chemotherapy in the spinal fluid. They may get intense treatment, which has side effects, and then they may need to do stem cell transplant. But patients are cured. I have patients. We're putting together a small case report. Now we have at least 4 or 5 patients since where we were focusing just since the advent, since the availability of tagraxofusp, who are more than 10 years out and are in complete remission, meaning they are cured. They're living a normal life. Some of them still come and see me once a year, which is very nice of them. They say they just want, and when I meet them, the conversation is more about their travel and family and excursions. So very rewarding. So it is still a potentially curable treatment. And with better understanding of the biology of the disease and availability of newer treatments, and I mentioned things like venetoclax, hypomethylating agents, new targeted therapies, we will have more options, and more options mean more and more patients getting durable remission and getting cured. And hopefully one day we may reach that point where patients may not even need to undergo a bone marrow transplant, as we have seen with so many other diseases, because we have very effective treatment that are less intense and less complicated.
And then we do have another audience question here that I wanted to address. But how do people know about specialists if their hematologist doesn't recommend them? They said they didn't know that they had specialists for BPDC in either Boston or Houston. I think
Sure.
this is the individual that said that her dad
Yeah,
had BPDCN, so
I'm
this
seeing
might
that.
be newer.
Yeah, so I'm seeing that, and this is so I think this is where resources like HealthTree and Lymphoma Leukemia Society, and I'm pretty sure there will be other, just like any other disease, patient advocacy organizations, which put those names on their websites, and that's how people find out. So we just have to have those resources, make them available to more and more patients, reach out to them, and like when I talk to my patients, I tell them if you need more information, these are the authentic sites where you can get more information about the specialists, about treatments, about the long-term care, survivorship. So I think those are the type of resources that we need more of. But things like HealthTree University, uh, the Lymphoma Leukemia Society, websites of specific cancer centers, although most of them do not recommend other centers because they are just talking about their own specialists. But if you reach out to some of the major cancer centers, like an easy thing would be what are the NCI designated comprehensive cancer centers, and check a few of them, that who are the specialists there. And
Yeah,
then I think Dalton, you've put this specialist directory. I think these are great resources.
yeah. So we do have a specialist directory on our website. I'm working to make sure that it's as up to date as it can be. And really, in the last, I would say probably decade or so, as BPDCN's gotten a little bit more recognition, there's just now starting to be some more of these BPDCN specialists, whereas before, um, the disease didn't have quite as much recognition, so there weren't too many people doing dedicated research and really spending a lot of time looking into BPDCN. But thankfully, that is changing now. And
Absolutely.
MD Anderson is one of the leading sites of that change. So, well, I think that looks like it's the end of our questions. And I think that we covered quite a bit here today. So, thank you again, Dr. Qazilbash. This was wonderful, and I look forward to seeing your slides. And just thank you for being such a wonderful, um, wonderful leader in this space and being so willing to share your knowledge. It is so meaningful.
Thank you very much. It's really my pleasure and very kind of you. Thank you very much, everyone.
Absolutely. All right. And then as we leave today's session, I did want to remind everyone about that short 2 to 3 minute long survey. You can provide feedback about today's event as well as suggest future topics. So that is very helpful. And then I did want to bring up a couple of upcoming events that we have. On October 7th, we have a bi-monthly blood cancer financial Q&A, expert answers to your treatment costs and support questions. And then on October 22nd, we have protecting yourself during high-risk seasons, prevention and immune support for blood cancer patients. So be on the lookout for those. They should both be very good events. I want to give one final shout out to AbbVie, our sponsor for BPDCN. Again, would not be able to do these types of events without their support. So thank you to AbbVie. And finally, I just want to thank Dr. Qazilbash again and thank everyone for attending live or watching after the fact. It means a lot to us to have your help in building this community. We're really trying to get as much education and awareness about BPDCN out there as we can. So being part of that really does mean a lot to us. Um, I have included my email on this slide. It's just Dalton, Dalton, at healthtree.org. Please don't hesitate to reach out to me with any sort of questions that you have. I'm always here to help the community. So anything and everything, please feel free to reach out to me. I'm truly available to you. And finally, I just want to thank you all again for coming. And I hope that you have a wonderful rest of your day. I am happy to stay on for a couple moments if anyone would like to speak with me, but I'm going to go ahead and close out the recording um, so that we can just chat if anyone is interested.